Those are alternating electrical fields at low amplitude, and living cells can be affected by those electrical fields because they have components that are charged, and thereby can be disrupted. So the generated forces of the alternating fields will disrupt cell division, but also interfere with the assembly of microorganelles, microtubules, and accordingly will stop cells from dividing. And these interact with the cell membrane, the spindle cell apparatus, and downstream pathways, as well as some other organelles. It affects the cell cycle at two major checkpoints. One of them is at metaphase, when you have organization of the chromosomes with the spindles forming to try and pull them apart. And the tubulin subunits are highly polarized. That's why they're very susceptible to the alternating fields. So it stops this process during metaphase. If it catches the cells during telophase, when it's the hourglass appearance of the cell, then it exerts a non-uniform electrical field, which causes a physical phenomenon called dielectrophoresis, which I'm sure most of you are not familiar with or forgot it from high school. But what it does, it pulls all the charged micro and macro organelles to the center, to the narrow part of the dividing cell, and then that leads to cell death by apoptosis. But there are many other mechanisms. Many of them are being investigated, and if you're going to attend the next SNO in San Antonio, there are going to be several presentations on this. But this is just some work that came out from our laboratory, where we looked at gene expression in patients who have had exposure to TT fields and then were reoperated. So we had the tissue after surgery as well as before surgery, and compared them to patients who did not receive TTF but were on chemotherapy only. So we did RNA sequencing to evaluate the alterations in the genome-wide expression patterns of these tumors. Small number, 6 patients receiving TTF and a larger control cohort, and compared them to patients with chemotherapy, and we found that 281 and 154 genes were either upregulated or downregulated significantly in an over 2-fold change that was very significant statistically. And these gen sets included many factors that were previously shown to play a significant role in GBM progression. So when we did some gene set enrichment analysis, we could see that genes affected by TTF were highly enriched in key functions related to tumor progression, including the EMT, the epithelial to mesenchymal transition, which was downregulated by TTF, as well as some genes related to cell cycle and others. And this data suggests that apart from the physical effects of TTF, this therapy results in deregulation of tumor gene expression, which is ubiquitous in many tumor types. So this is the apparatus that one uses for TTF. You can see that those are electrodes that are placed on the scalp, and the patient carries a battery that feeds on that apparatus. It currently weighs about 3 kilos. The new model weighs less than a kilo, and patients adapt to it very quickly. From the initial study that was a phase 3 study in recurrent GBM, I'm just going to show you a few examples. There were many more responses that were seen in the control arm, but those responses took time, as was also seen in the preclinical work. So, for example, this tumor took about 6 months until it showed some partial response, which was significant. This complete responder took about a year until it changed from this recurrent GBM to no evidence of disease. But most of the information after this apparatus was approved by FDA back in 2011 for recurrent GBM was gleaned from what's called the PRIDE study, the post-registration study. So overall, until now, I think about 1,000, maybe 1,500 patients in the US alone have been using this device, the TT fields, to treat recurrent GBM. And the data showed, in contrast to the initial study showed exactly the same overall survival and progression-free survival with using TT fields versus chemotherapy, with a significant improvement in quality of life for patients because they didn't have all the side effects of chemotherapy. But when we took the PRIDE data of these patients, we could see that while this was the survival curve from the recurrent GBM study, this is the survival curve of patients with recurrent GBM treated after marketing of the device. Several differences existed between the two cohorts. One of them, in the study, it was a monotherapy, so patients used only TTF. In the PRIDE study, in post-marketing study, most patients, almost all of them, were receiving an additional chemotherapeutic agent. In this case, over 90% were on Avastin, in addition to the novel TTF, the TT field. So this resulted in a significant survival advantage. The other reason is that during the study, many of the investigators did not realize that it takes a long time until you see responses, and they were taking patients off the device prematurely. Nevertheless, with the PRIDE study, you can see that the 2-year survival rate was 30% for patients with recurrent GBM, and compared to patients that only 9% were alive at 2 years, a significant difference. But probably one of the most important factors was that the time or the compliance of using the device resulted in a very clear difference in outcome. So in the recurrent study, patients who used the device for more than 18 hours had a significantly longer survival than patients who used it for less than 18 hours, almost doubling it. With the post-marketing study, it showed that this difference was even more robust, with almost tripling or quadrupling the survival time of patients who were more compliant. And this device carries this chip that can actually measures the duration of time a patient is using the device. So there is a clear correlation between the time of exposure and outcome of these patients. But this led, of course, to the study, to the phase 3 study in newly diagnosed patients. Patients randomized 2-to-1, either receiving the Stupp protocol with TTF or just the Stupp protocol as it is. And over 1,000 patients were screened, but 700 were enrolled in the study. And data analysis consisted of doing an interim analysis after half the patients, 315 patients, were enrolled with a follow-up time of 18 months, and then subsequently to do the analysis for the full data set. So based on the interim analysis, which we presented at SNO last year and showed significant PFS and overall survival in patients in TTF, the Independent Data Monitoring Committee recommended to stop the study for success and allow patients in the control arm to cross over to the treatment arm. At the end of beginning of this year, we got the complete data set, and that showed very similar data as for the interim analysis, with a significant advantage for progression-free survival in patients with TTF that translated also to overall survival in these patients, about 3 months advantage of survival. But the protocol, when it was written, and we've seen in the preclinical data that you need exposure for at least 1 month for the device to see the effect. So in the protocol, it was also designated that patients will be analyzed as treated, meaning that only patients after receiving the device for 1 month will be analyzed. This is in addition to the ITT, which I showed you previously. And when looking at as-treated patients who were at least 4 weeks on the device, then you can see that there was almost 5 months difference in survival in these patients, and this is the overall survival curve, and was even more pronounced for the PFS. We looked at many prognostic factors. I'm just showing you that this is consistent. Patients in this example with methylated and non-methylated MGMT showed a significant survival advantage for those. But when we looked at all the subgroups, you don't need to see what's written here, but what we did, we took all the subgroups of patients older and younger, patients who have good KPS, poor KPS, methylated, non-methylated, and so forth. For every one of those subgroups, there was a distinct advantage, both for progression-free survival and overall survival. So this methodology or this technique is not active only in a subset of patients with GBM, but in all of them. But let's move now to the brain metastasis. This is a metastasis meeting, probably the best in the world. There are no such meetings, and Philippe has been very adamant about doing this for many years, and he should definitely be congratulated for it. So what do we know about using the TT fields for metastasis? TT fields should act on any tumor, not just a primary malignant brain tumors. And in fact, the preclinical data we and others have done have shown that many tumor types are sensitive to electrical fields, except that they need a different frequency, which is in part related to the size of the median size of the tumor cells. So GBM are being treated at 200 kilohertz. But other tumor types, such as lung cancer, should receive a higher intensity, higher frequency, while breast cancer should receive a lower intensity. And we have now a catalog for most of the tumor types showing the precise or the optimal frequency that needs to be used. This will not work. This was a short movie. Ah, amazing. Is there sound for this? This is a very short movie, but all right, well, what it shows, this is looking at ovarian carcinoma cells. And we've done studies in vitro on many tumor types. Well, this is the culture that's exposed to TT field. On the right side, you see the control slide where the culture, where those ovarian carcinoma cells grow uninterrupted. And after several hours, this is time-lapse microscopy, of course. So after several hours, you can see that cells exposed to TT fields do not go mitosis. When they try to line up for mitosis, they get some abnormal blebbing and finally disrupt and die from apoptosis. While on the right side, the control culture just continues to grow all the time. And we've done all the stains to demonstrate that this is associated with the nextin expression as well as others. And I think it's quite clear that this tissue culture is nothing like what you see in the control arm. So I think we can skip this movie for purpose of saving some time. And we'll go on. So very preliminary studies, this was done over 10 years ago when we were just playing around with those electrodes. We tried it on some skin lesions. So this was a melanoma. First time electrodes were placed over the melanoma here, and you could see some response even after 2 weeks. It didn't go away, but you can appreciate that the size and the consistency of these tumors changed significantly. Another patient was with skin metastasis from breast cancer, and here you can see the lesion before electrodes were placed or electrical fields were applied, and a short time after that you can see shrinkage of the lesion, volume and size getting smaller over time. Minesh showed you this slide yesterday. This is a series of some very interesting experiments where we're looking at prevention of metastasis. So in this study, it was done with melanoma injected into tail vein of mice, and the endpoint was to look at the number of metastases in the lungs. So the TT fields were applied to the lungs of these mice, and you could see that over time, the treated lungs showed very, very few metastases, while the controls showed an abundance of metastases. So this was a first evidence that TT fields can prevent deposits of metastasis in distant organs. Another study was done in rabbits, and this was to see if we treat the original site of carcinoma, if we can prevent metastatic processes to the rest of the body. So these were rabbits that were inoculated with renal cell carcinoma in the subcapsular area, and we looked at the lungs, not at the kidneys, but the TT fields were applied to the kidneys. So here is TT field treated rabbits, and these are the controls. And if you look at the weight of these organs, number of metastases and so forth, you can see that there was a significantly lower number and smaller number and smaller weight numbers of metastases in the treated animals, meaning that you can prevent metastasis by treating the original site as well. So you have two mechanisms by which you can reduce the incidence of metastasis in these patients. So the study, in addition to the brain tumor studies, company's done numerous studies and is conducting numerous studies for other tumor types. This is just an example of electrodes that were designed for non-small cell lung cancer. And this is a phase 2B study looking at patients treated at the same sites where they use evaluated pemetrexed, Alimta, for high-risk non-small cell lung cancer. And you could see that there was, compared to the same sites, historical controls, there was a significant survival advantage of these patients. And what more, since Alimta is not active against squamous cell carcinoma, TT fields appear to be equivalent both for adenocarcinoma and squamous cell carcinoma in these patients. And it showed some disease control rate, which was quite high, but of course this is a phase 2B study, and this will now be translated into a larger phase 3 study. And images showed some similar findings that we've seen in the brain, that you see these tumors, but it takes many weeks until you see resolution of those lesions. Looking at physical characteristics of TT fields, we know that we can cover the entire brain. And more than that, if we do an optimization of the layout of those electrodes, we can even target specifically a lobe of interest in getting a high intensity of the electrical fields. So this led to the assumption that one can use TT fields for either treatment or prevention of brain metastases. And there are 2 studies that are looking at that. This was in an ongoing study over a year now. This is a phase 2 randomized study. And this is using 150 kilohertz frequency, because this is optimized for the use of non-small cell lung cancer. And patients with 1 to 5 brain metastases after receiving their optimal treatment. So it can be radiosurgery, it can be surgery, whatever it is. Patients are randomized to receive TT fields or just supportive care based on standard of care. And endpoint of this thing, looking at time to local and distant progression in the brain. The other study that Minesh mentioned yesterday, and there is a poster outside that you can look at it with more details, is the METI study. This is going to be also an expanded phase 2 study. It's going to be open label and randomized study for TT fields at the same frequency, following SRS with or without TT fields for up to 10 brain metastases from non-small cell lung cancer. Again, endpoints time to first intracranial failure. So to summarize, and what's now known with TT fields, for GBM patients, there's just no question that this should be offered to patients as part of the standard initial treatment for their disease. We know that there are many additional mechanisms, including molecular mechanisms that play part besides the pure physical characteristics of TT fields, and they may be effective as a metastasis prevention tool in the brain, as well as a treatment device for other systemic malignancies, such as pancreatic cancer, mesothelioma, ovarian cancer. All those are being investigated now with the treatment of TT fields. Now, laughing into innovation is not new. We've been working with this for several years, and we got a lot of heat until we could demonstrate unequivocally the data from the phase 3 study. And even then, there are those who criticize that and call this thing a placebo effect. But we're fine with adding 5 months survival to GBM patients with a placebo effect. That's absolutely okay. But some people do not think that this is really funny. And for example, the World Economic Forum this year, just a couple of months ago, selected Novocure, the company that makes it, as a technology pioneer for 2015. So I guess some people are not really stupid in looking at the merits of what's happening. And with that, I'll conclude, and we'll take any questions if you have any.